Good afternoon. So welcome to our Innovation Insights webinar. As we get people coming in, I'll do quick introductions in terms of what the talk will be about today. As the title suggests, we'll be talking about bridging health gaps in prevention, making cardiovascular more accessible in community pharmacies. As a way of introduction, my name is Jagjot Chahal, and I am a cardiovascular prevention pharmacist at Barts Health. And I'm also delighted to present to you also Rach and Aurora, who'll be presenting with us today as well. So Rach, if you'd like to introduce yourself.
Yeah, hi, I'm Rachana. I'm one of the senior implementation managers working at UCLPartners, supporting this program. Really a pleasure working with you. I'll pass it on to Aurora.
Good afternoon, everyone. My name is Aurora Todisco, and I'm a steering group member representing people with lived experience. Nice to see you.
That's great, thank you. So the main crux of today's presentation is really about talking about the innovation that we've started as of this year in community pharmacy, bridging those health inequality gaps in CVD, and then talking you through how we've developed and co-designed that with the local population. So going straight into it, what the innovation is to complement the blood pressure testing services, which is successful in community pharmacies. So locally, we're working in North East London, which is 2 million population. And when we talk about that blood pressure testing service, it is live across a number of pharmacies in North East and North Central London ICBs. So if we look at the blood pressure testing service, as of April 2025, just over 17,000 patients access that service. So what we wanted to do is to do a more holistic approach. When a blood pressure test is offered opportunistically, we wanted to make sure actually while you're doing that, making it more of a mechanistic, making every contact count, to then offer a cholesterol test. So the way this service is, when the patient's onboarded, is opportunistic, and then it's a finger prick test where the result comes back in 7 minutes, and then it's the full lipid panel, including a Q risk, is then presented on a dashboard, so you can see the Q risk there. So irrespective of what that result is, then there will be a requirement for the pharmacy professional to then give lifestyle advice, and then if needed, for onward referral or manage in-house, which we'll come on to in a little bit. So you can see at the bottom of the slide here, there's a number of stakeholders were involved as part of this. So kind of to let you know what each organisation was took part in is firstly is Barts Health, which are clinically supporting with the multidisciplinary team and pharmacy professionals with the governance oversight. We've also got ALOPE, which is our East London Cardiovascular Disease Prevention Group, and we've also got East London ICB, which supports with the governance oversight and the system partner. Similarly with North Central London ICB. Then we've got our local pharmaceutical committee in North East London, which are representative of community pharmacy, so a key stakeholder there. UCLPartners, which are supporting. So this program did start with the INHIP program, which is the Innovation of Health Inequalities, and they're supporting with the Adopt and Scale. So as you see, this is kind of a growing program at the moment, and is also the independent evaluator of this program. We've also got Heart UK, which also supports with the patient and public engagement, and also NHS England and HealthStat, which is the industry partner. So the aim of the service is to identify people at risk of having a heart attack or stroke in the next 10 years, if they are identified, to then offer a lipid lowering therapy, and then empower the patient. So when I mentioned the dashboard, you can see on the right hand side here what that dashboard looks like. It's a traffic light system which empowers the patient, where they what they need to do next. And essentially, when that result comes back, there's then literature we support with our pharmacy professionals to make sure that we give culturally appropriate advice to our patients. So it's really tailored to the individual who's doing a personalised approach. So this is what the criteria looks like. I won't go to this in too much detail. It's really just to demonstrate there is a criteria for inclusion and exclusion. So the main exclusion is if the patient does fit the national criteria for doing the blood pressure test service, they can then be offered this straight away. However, we did identify, talking to our public health partners, that actually patients with type 2 diabetes, again, tend to have higher risk of CVD. So we broke that down, age gap down from 35 to 25 years, because again, when we're looking in the acute sector, we are seeing people younger and younger presenting with heart attacks and not necessarily being picked up early in the NHS health checks. So you can see we've also got an exclusion criteria. So while you're waiting for 7 minutes for the result, the patient will have their blood pressure measured, height, weight, smoking status also confirmed, and that is inputted into the tablet, and then that will then work out the Q risk for the person. So this is really, again, I appreciate it's a busy slide, but really it's just to show you and demonstrate that there's a pathway in terms of once that lipid panel then appears, how it's interpreted. So the first thing is to interpret the triglycerides, and if that's raised, to repeat the test. And if it still remains raised, then it was to then to inform the GP via pharma outcomes. Similarly, where you've got step 2, this may potentially or possibly be familial hypercholesterolemia, where patients tend to have significantly higher risk of having heart attacks or strokes. So then again, it's really to onboard and refer to the GP for further investigation to investigate that. So then you've got step 3, which is predominantly the large cohort of patients that we're seeing identified as high risk. So if they are identified as high risk, so Q risk above 10%, to then refer on to the GP to initiate. However, if everything's okay and the Q risk is less than 10%, still communicate to the GP that we've done the test to inform them it's been done, so it doesn't need to be duplicated, and these are the results. Similarly, there is a national pilot happening where there's the IP Pathfinder, Independent Prescribing Pathfinder program across the country. So this also aligns to that as well. So for pharmacies that are able to prescribe and are using the lipid model for prescribing, there is then option, instead of referring on to GP, to actually then finish off with prescribing, as opposed to from testing all the way to prescribing. And then what's also pleasing to kind of share is that the test, once the test is sent to the patient, it's emailed to them as part of this process. They can also authorize it on the Patient Knows Best app, which enables it to be viewed on the NHS app, and that's kind of what the view looks like. It's really digitally enabling. In terms of how we've selected the pharmacy site, so you can see we started in North East London, and this is the orange boundary here is the boundary of our ICB. The red areas are your core 20 areas. So when we talk about IMD or deprived areas, it's your IMDs 1 and 2. So your core 20 when we're talking about the NHS vision addressing health inequality. So you can see predominantly all the pharmacies are in there, which is represented by the purple dots. Similarly, in North Central London, you've got your boundary there, and most of the pharmacies that have been located are within the areas of highest deprivation, so your core 20 areas again. So what have we found since we've gone live? So we went live in January. So the data up until October is that we've tested just over 700 patients, and of them, consistently through the program, we've identified 20% of patients having a high risk of CVD. So unsurprisingly, there are many people actually wanting to opt for lifestyle first before initiating statins. So in terms of following up these patients, we've got a 3-month lag before we see if people are really, there is an uptake of the statins and optimization of lipid management. Of the significantly raised lipids, where we said it could be possible FH or familial hypercholesterol, we've identified 12 patients. And of the people that have been identified as Q risk above 10%, we've had 34 patients started a statin, and more than half of them started within 2 weeks of being tested. So that's kind of the feasibility of the pathway in terms of tests to getting the medicines optimized. Similarly, like we said, the second cohort of what we are testing are patients with diabetes. So what we're finding is that actually 60% of patients with type 2 diabetes with a Q risk above 10% are not on lipid-lowering therapy. So again, something significant there in terms of those cohorts and those patients. So when we talk about deprivation, who's actually accessing the service? So you can see here in this graph, we've got the blue bars, and these blue bars show us who's accessing the services. So this down here, we've got the IMD across how many patients. So you can see again, predominantly patients in the core 20 are accessing, and subsequently the orange pink bars are more really they're the ones that have been identified. So it's really again making sure we're addressing the unmet need. Similarly, we're also then capturing patients' ethnicities. So we've kind of the top 3 is prefer not to say Bangladeshi, white British. We've also got Afro-Caribbean. So they're the top ethnicities that are accessing the service and again, subsequently being identified. What we have found from previous wave 1 in HIP is that people who state prefer not to say tend to be from ethnic minority groups. So kind of targeting again people that may be at a higher risk. Similarly, what we also looked at is for people they've also inputted or they've also shared what other comorbidities they have. And unsurprisingly, what we have found, people with the lower IMDs tend to have the most comorbidity. So kind of the yellow bars here showing people got 3 or more comorbidities, and that tends to increase in areas of deprivation. So in terms of the implementation, how this was rolled out, this did require some robust training for teams that may, point of care testing may be a relatively new component of their work. So this involved doing some e-learning modules, practical hands-on training. So that's kind of represented in the picture there. Also followed by case studies. So again, interaction using webinars, and then being signed off. So being assessed on their technique of finger pricking all the way through to how the lipids being interpreted, and then again making sure there's a plethora of resources to share with the patients, but also use to support the consultation. So we've got kind of a snapshot there what that looks like to support patients. So a common question we get asked is the equipment, the accuracy of the results, and what can be done once those results are available. So recently there was a publication where it says 2/3 of cholesterol point of care testing fails to meet standards, what researchers have warned. So to kind of do our due diligence, first of all, the machine we're using is the Health Hub Affinion 2 machine, which is externally certified by the Centre of Disease Control and Prevention Cholesterol Reference Group. And we also made sure that it complies with the NHS England requirements for point of care testing to implement in community pharmacies, and also the MHRA recommendations. The other things we also do is we make sure that there's internal monthly quality control and also a quarterly external quality control again. So this is diagnostic. It's not to repeat tests in the system. It's to make it more efficient, and it also improves patients' experience. So at this stage, I'd like to hand over to Rachana.
Thank you, Jax. So my section's really about talking about the approach we took with PPIE. So our aim has been to make sure that people with lived experience and those using the service are actively helping us shape the program. So listening to what they want, what they need, what they and constantly using those to improve. So we've decided to go with a 3-phased approach. Phase 1 was really kind of working with our pilot site. So not thinking we know everything and making everywhere the same, but learning from that pilot site. Phase 2 is all about understanding the user involvement. So more about surveys and understanding how they feel about the acceptability and accessibility. And phase 3 was follow on service, so more kind of one-to-one interviews to get in-depth details. So I'll go into that a bit further. Next slide. Next slide. So we really started in Newham with our first pilot site. As you can see, what Jag said about the deprivation, it's got a lot of deprivation there, so there's a lot of unmet need there. So we started off with a patient public involvement and engagement workshop to help co-design the pathway. This was done in early October 24, and we began by working closely with the pilot sites in Newham to identify and reach the target communities. Through surveying the local communities, we explored people's visibility, understanding, and their experiences of point-of-care testing, looking at what makes the service accessible to them, what makes it acceptable to them, and is this relevant, and is this something they would be keen to go to? But also things like, are they aware of what's already existing in their local pharmacies? This early engagement really helped us understand initial barriers and enablers before scaling the service further. Next slide. So here you can see we surveyed around 7 people in the local community, keeping health inequalities in mind. We did try and get different ethnicities and both kind of age ranges as well. Sadly, we were only, yes, and genders. Thank you. So here is what we heard from them. So this is kind of the results that we heard from them. So they're really more about awareness and promotion. So how do we get local communities aware of this program? There's new services that are happening in their local pharmacies. There's a really great quote. I didn't know community pharmacy did free blood pressure checks. And then someone else said would be helpful to advertise services in places of congregations such as supermarkets, libraries, hairdressers, and Facebook groups, as well as GP practices. So this is so thinking about that, we created a poster with our lived experience and our patient cohort. People said about making sure GPs were aware of the services, and then the accessibility and convenience. so one of the patients said, I'll go for the test if it's walking distance, so making it easier to do the test. Pharmacies are seen as quick and easy places for testing, but only if people are aware of the offer. Walking distance access is key, especially for those with limited mobility. So thinking about health inequalities again, and how people can just go to their pharmacy, do the test, and get the results in 7 minutes. Next slide. So there's lots of kind of stuff here. So with the so understanding the results and follow-up. Most people are used to going to their GP services. However, will they feel comfortable and confident going to their pharmacist? So strong need for clear explanation of results would need to happen, and what term means what and what actions to take. Follow-up and signposting instructions, and kind of having multilingual information for people who can't English isn't their first language. People are comfortable testing either at the GP or pharmacy, which is nice to hear. And some rely on GPs for health information, so joint visibility is valuable. Many only some of the things. So many only visit pharmacists when unwell. However, so that's kind of looking at the barriers. So they may miss services or may not be aware of the services. And motivation engagement really is about kind of friends and family, personal friends and family health events, can motivate proactive health checks, and also doing that friends and family test. So if I've been, I'll let my friends know, my family know, saying the service is happening. So a word of mouth. And it's quite nice to see that 100% of respondents would recommend the cholesterol test to your friends and family. Next slide. So we did lots of feedback. So once the residents had done their lipid test, we asked them to fill out a survey. Doesn't take long. So all those information helps us improve the service and make sure we're constantly making changes to help the system. So as you can see, this is phase 2. So there's a strong need for clear explanation. This is such an incredible service to have access to. There's heart disease in my immediate family. The time saved is invaluable, and this service no longer warrants an online submission for a GP, wait of 3+ weeks for an appointment just to request a blood test, then having to go to the medical centre for blood tests, followed by the results to be processed before contacting my GP again. Most people work full-time, so this is, I work full-time as a secondary teacher. Please continue this service for local community. So when we think about health inequalities, it's not only about those that are deprived, but it's people that go to work and are unable to take days off or time off to go see the GP services. So that was really nice to hear. Next slide. Yeah, thanks. So our phase 3 approach was really about getting in-depth information, so interviewing. So we interviewed about 10 residents who had done this test, and as you can see, the feedback was brilliant. So as an Asian, we have lots of butter and lots of oil. So just to alternate, they gave a list of things that we could do alternatively. So really thinking about the local community, targeting it for the individual rather than the masses. I now take around about 30-40 minute walk a day. The service could generally save lives and money, and it takes about 8 minutes to get your results. No brainer. It's life-changing, especially for people like me who work long hours and for older people like my parents. And finally, in the pharmacy, it was fantastic. I mean, they were very polite and very helpful. There's no waiting. I was given a time slot and I was there 5 minutes before, and I was seen literally about 2 minutes or 3 minutes before my actual time slot. So as you can see, the feedback is really great and has been really valuable. We constantly look at feedback. We're constantly making changes and making improvements. Next slide. So this program has been recognized to start meeting the ambitions to support NHSE's 10-year plan with the 3 shifts, specifically treatment to prevention. Here is a link which I'm happy to share the slides with everyone if they're interested. Here's a link to a case study which Dr. Ralia Onatad did, chief pharmacist, which is in NEL ICB, who's one of the advocates for this piece of work and believes this will help reduce some of the gaps in health inequalities due to accessibility. This piece of work has also been recognized by NHSE. Professor on the left, on the right, you can see Professor Kevin Fenton, who's the Director of Public Health Advisor to London Mayor, who came to one of the pharmacies during Know Your Numbers week to inform local residents that this service is available. And there's lots of information, case studies on this as well. Next slide. Thank you. So this is a really nice quote that has been taken from Stock Take Report, which really outlines neighbourhood working in collaboration and service designs to support the local residents. So personalised care approach, what matters to me, not what's the matter with me. And I'll hand over to Aurora.
Thank you so much, Raj, and good afternoon again. Before we dive into the patient perspective, I would like to provide you with a bit more background about myself. I've been a steering group member since group inception as a PPI representative, and I was previously sitting on the UCLP CVD Academy steering group, and I'm still sitting on the National CVD Prevent Program. To be honest, I don't bring personal lived experience, but I do bring carer oversight and a strong focus on how services are perceived by residents. So I was recruited by the UCLPartners PPI team as I am a resident of Newham and I work with the health and social care sector in North East London. I work for a charity organization called Local Voice in the Community, where my role is in HR and finance. But before this, I also served for 2 years and a half at the Health Innovation Network in South London as a lived experience partner, advising project manager on how good PPI looks like in real and practical terms. So going back to the program, so we just review some sort of impressive data and feedback on the rollout and the clinical need for the CVD risk assessment in community pharmacy. And it was delivered through, obviously, the point of care testing. But before we finish, I want to bring the focus back to what truly ensures the long-term success. That is the resident and patient perspective. So as a PPI representative, my role is to translate clinical strategy into the real world and accessible healthcare for obviously the diverse community of Northeast and North and Central London. So my insights come directly from listening to people with lived experience. So why I was committed to this role? Let me start by sharing my involvement and why I was motivated to take on this role. My role is simple, but really vital to the program. I sit in the steering group. We meet every 6 weeks. Obviously, I'm not a clinician. I'm a community advocate. And I try to channel the feedback, giving input from the design throughout the evaluation. And I act as a check on health equity. I've seen firsthand, obviously, the barrier that many residents are facing when accessing primary care. And for many, even a cholesterol check means taking a time off work, like Rach was mentioning before, and trying to navigate complex phone system or waiting weeks for an appointment with the GP. So I think we are talking about a good definition of health barrier, unfortunately. I think this model is quick, is local, is accessible, and it feels like a genuine game changer. So my motivation is to make sure this innovation obviously is working for everyone, and especially those who are underserved or they have unmet need. Because convenience should not be a privilege, obviously. Our health needs should be a right. Speaking about impacting strategy and process, my involvement has focused on 2 key areas. Number 1 was accessibility and communication. So in terms of accessibility, we explore what the patient journey should feel like. The ideal experience, obviously simple. You walk into the pharmacy, you take the 7 minutes test that has been described earlier, and you receive a clear and immediate advice from the pharmacy. So I help them to ensure that simplicity was becoming reality, and I try to emphasize the need for a private consultation space, because despite all pharmacies are equipped with a consultation room, the practical logistic interaction in the pharmacy, sometimes they create a sort of barrier. So it's not always easy to have this dedicated space. And then I was trying to push for obviously an easy referral pathway when more care was needed. Maybe you need to follow up following your appointment, etc. The goal overall was to make sure, obviously, the service were feeling integrated and the patient was not feeling isolated. Then in regards to communication, at the start, The launch material obviously were full of acronym, there were some clinical terminology, and I was pushing for plain and accessible language across all the patient-facing material. There were leaflet, poster, and social media content to be reviewed. And we had a closer look together at the poster design, for example, and we made sure it was using some clear visual, some diverse images, and simple and empowering messages that were resonating for everyone. And because pharmacists are always reflecting, are often reflecting their local community, they help us to make sure translation were authentic and also trustworthy. So I think this change shifted the tone from intimidation to empowerment. You know, from the message, book your lipid profile appointment because it's needed, you are at great risk, etc., to walk in and take control of your health. So you gain knowledge and expertise about your health and you use it to have better outcome. We also try to ensure that material were in community languages. And I have to say that, for example, UCLP co-produced blood pressure video in 15 languages, and they are available on our YouTube channel, and this is great. And this change improved the uptake, the trust, and the confidence from patients. In relation to ensuring equitable representation, obviously I want to put out a question. What does this program represent for everyone? So obviously I work to challenge assumption about equality, and just because a service is available to all, it doesn't mean that it's accessed equally by all. So perhaps in the locality where I live, Northeast London, you all know that is one of the most diverse area in the country, and we will keep asking ourselves, who is using the service and who isn't using the service? If not, why isn't they're not using it? So every 6 weeks, we were reviewing the data, and I try to highlight how broad some ethnic category are. Taking in consideration my own ethnic category, that is other white, I was trying to highlight that it was including many community. So obviously I try to describe myself as an European, but because my appearance or religion can shape how people perceive me, it can also affect how people are engaging with care. Some community have some language hesitation, other have some low health literacy, and they are not very familiar with risk and terminology such as familiar hypercholesterolemia. That's why every 6 weeks we try to run through the evaluation process matter, and if uptake was lower in certain postcode or group, this was not seen as a failure. It was just a signal to adapt our approach. So we start to adjust communication and outreach accordingly, and that's how we move from equality to true equity. Obviously, you need to guarantee fair access and fair outcome for everyone. So what I'm seeing for the future as a growth and point of risk, we need to ask ourselves again, how do we get more resident and patient involved in future innovation? We need a formal pathway for co-design. So going beyond, obviously, the feedback survey that we received so far, people with long-term condition often experience healthcare differently from those who are currently healthy. They have a fragmented journey across the system, unfortunately, but we need to analyze both perspectives, people that are currently healthy and people with comorbidities. So my suggestion was a tighter approach. There was a patient critique, so I was suggesting to have a small group of residents testing things like a digital interface and run some co-design workshop, trying to involve residents from the concept to the delivery and embedding lived experience at every stage of the process. I think this is keeping the innovation grounded, inclusive, and also practical. But we also must be mindful of the unintended consequence. If a service becomes too convenient, some patients may disengage from their GP. And we need to communicate clearly that the POCT complement, obviously, the GP care. It doesn't replace it. We need still to have good communication between pharmacy, patient, and GP, because it's the key of keeping the system connected and safe. Just to wrap up my contribution, obviously, I believe patient voice doesn't need to be a tick box exercise. is a strategic driver for equitable access and meaningful innovation. And by keeping this level of scrutiny, collaboration, and shared purpose, we can make sure that this program continues to deliver real and equitable impact for people of both Northeast and North Central London. And if you like to explore more our patient engagement model and collaborate with our team, there are contact information there on the final slide. And now I will hand over back to Jag. Thank you.
Thank you. That's great, Aurora and Rachana. So yeah, just kind of finishing off with what Aurora had mentioned is that there is some resources that have been created by UCL Partners. So for people that are already being diagnosed with hypertension, there are videos available in 14 different languages to support patients and people in the population in how do you manage or monitor your blood pressure appropriately. And in particular for the cholesterol management within this service, we are using Heart UK literature, which talks about a lot of the things in terms of certain communities like South Asian communities, Afro-Caribbean communities, and what do you swap certain foods to kind of more healthier things, which actually feedback we've got from our pharmacy colleagues has been really helpful and tangible for people to go away and try out. In terms of other tools we've used in the past is that there's the health literacy home. So if you were to put in, if you're thinking of creating some documents for patients to kind of support with any literature to kind of go away and read, there is a website here which you can put in a postcode and it will tell you what the reading age of that population is. So really important when we're talking about disseminating literature once they've gone past that consultation. So this is the contact details of the team, and happy to open up for any questions. Oh, I think there is a Q&A function, so any questions?
Hi, it's Annie. I've just got a question just around the videos that you did, and it's fantastic that they're in so many different languages, but how do you proactively get them then shared out into the communities that they're targeted for? Did you have an action plan, or were there particular groups that you were targeting to get those messages out?
So I can answer that. So originally when these first came out, there's the program called the BPO program, so blood pressure at home program, where people were doing the blood pressure at home and didn't always have English, wasn't their first language. So that's when the original of these languages videos were created. So anyone part of that program, the ICBs would pass this information to them and they would socialize it out. That was one way. And the other way was that we'd go to different pharmacies and have this conversation with them. Do you know we've got this? GP surgeons, do you know we've got this? You know, whoever we're speaking to, kind of word of mouth. So those are the kind of two approaches.
Lovely,
Hopefully.
Fantastic. Sorry, just whilst if anybody else is thinking of a question, just I was just wondering, was there any particular challenges that you faced? Was there any particular, not naming pharmacists, but was there any particular like pharmacy areas or anything like that that you had challenges, or did you find that it was an open door to this program?
So I'd say the first main challenge we had was actually at the outset. So getting this program set up did take us a while because we are using new technology. So there's lots of governance processes we need to go through. So whether that's using the technology, so has it got the DTAC? Does, you know, so particularly when we're talking about using cholesterol, any point of care testing machines, does it do what we're kind of wanting it to do to deliver what we want to do as part of that service? And then that was one element. Then the information governance. So all the information we've presented today is with, you know, making sure that the information governance that we are collecting, that it is, you know, there's consent there, and there's only people that really kind of need to know basis, and pseudonymized where required for further evaluation. So that's kind of what we did. The other barrier or thing to be aware of when, you know, implementing such services is really trying to understand that setting. So whether it's community pharmacy or anywhere else really, when it comes to clinical services, is that there tends to be that variation. So within community pharmacy specifically, there's 2 models that we came across. So you've got some pharmacies where you've got a second pharmacist model, and that's where they're delivering more clinical services, and and so they have a set time aside to see patients. So that's that. And then the other service is where you've got a pharmacy technician-led service, where they're doing more the practical day-to-day running and be able to escalate and triage patients that need to be seen if they've got high risk identified.
Oh, amazing. Thank you for that information. Kathleen has asked in the Q&A, is this offered in any other areas of the country?
So should I take that one?
Yeah.
So in terms of which I didn't actually say, was we are live across 13 pharmacies, and the way this service started out was opportunistic blood pressure testing to complement to complement the blood pressure testing service. So what we wanted to do was to then, as this project evolved, it then did align with the IP Pathfinder site. So as we speak, we are rolling across nationally to other IP sites. So we are working very closely with NHS England to support not just the testing element for the sake of it, but also testing and then leading on to a prescription if required for those patients. So it is live across, it will be live soon across a number of ICBs in selected pharmacies that are already delivering the independent prescribing Pathfinder model, particularly where they're looking at managing lipid optimization.
Also, there's a question in the chat. Are there any publications on this research?
All right.
Yes, there are. So there is stuff out there. So I'm happy if you put your email. I'm happy to share stuff with you if you're interested in that. Roman via. Or we'll send the slides and you can contact one of us. Any other questions, thoughts?
Just following up from the Midlands. So there may be some sites in Midlands that are doing the IP site. So your ICB will know which sites they are. Anyone else for questions? Well, that's great. Thank you, everyone, for attending our session, and a big thank you to co-presenters Rachana and Aurora. So like Rachana said, there will be an interim report out soon, so please do watch out for that to talk about our first part of evaluation, particularly where Aurora's talked about her input in that. So a big thank you to co-presenters, and thank you for attending.
Thank you, everyone.
Thank you so much. Bye-bye.